in school, I mean, really soak it all in. Ask the quote unquote, stupid, not stupid questions. It doesn't matter what you think about your question. I mean, if it's something in your head, there is somebody else that is also very likely thinking it.
Hey, VetFolio Voice. What's up? What's up? Thank you so much for joining me. I am so excited for this episode. This one took a little bit to get on the books, but I am thrilled that we finally did it because in this episode, I'm joined by my dear friend, Dr. Ishita Shah, to talk about her experience making the jump from general practice to emergency medicine. We talk about it in the episode, but Ishita and I started working together in general practice not long after she graduated, and after a couple years, she moved over to practicing emergency medicine. And while I sorely miss working together on a regular basis, her and I really made a good team. It's been so rewarding to watch her grow and excel in this new field that seems to be a source of challenge as well as fulfillment and joy for her. If you're in general practice and maybe you're thinking about making the jump to emergency medicine, or maybe you're a new graduate and you're contemplating general practice versus emergency, internship residency versus going straight into practice, I think Dr. Shah offers some great insight into her experience wrestling with those questions and the decisions that she ultimately made. And it may offer some insight, some guidance to other people who are grappling with similar decisions. And that doesn't, of course, only extend to veterinarians, but also technicians. There are some considerations in here, maybe if you're thinking of switching from general practice to emergency medicine and wondering about scheduling and flow and things like that. I really think there's something in here for everyone. As a side note, I was so proud of us for keeping this recording to the time frame that we did, because both before and after we hit record, we couldn't stop talking. It did make me late for the recording I had following this one because we just kept chatting and just couldn't stop. Okay, let me go ahead and introduce Dr. Shah and let's jump in. Dr. Shah is an emergency and critical care veterinarian at Community Care Veterinary Specialists. Born and raised in West Palm Beach, she's a double Gator, having earned a bachelor's in zoology and her doctorate in veterinary medicine at the University of Florida. She has experience as a veterinary technician and worked with numerous species such as sea turtles, reptiles, and birds. Her professional interests are internal medicine, surgery, and emergency medicine. And in her spare time, Dr. Shah enjoys family time, travel, baking, stand-up paddleboarding, working out with her fiance, and running with her dogs. All right, let's go ahead and jump into our episode. Hope everyone enjoys it.
Nutrition is the cornerstone of our patients' health and happiness. The veterinary healthcare team should be the ultimate source for top-notch pet nutrition info. When clients see how the right diet helps their pets stay healthy and happy, they visit us more often. Remember, good nutrition is essential. It's smart business and great medicine. Enroll in the NAVC Pet Nutrition Coach certification today on vetfolio.com.
Well, I'm super excited for this episode because I'm joined by Dr. Ishita Shah in person in Gainesville, which the in-person is fun anyway. And I feel like I've been trying to talk you into this for a while.
For a long time.
Finally did. So thank you for finally agreeing to come and talk to me on the podcast.
Thank you for having me. I am very excited to be here. I'm glad we could finally make this work.
Me too. Because we have like this funny history together. Yeah. Where we started working together right after you graduated. We're working in GP, and then you have since moved and now you do emergency for the same organization. So what was that like, kind of that transition between GP? Like, did you know you wanted to go to ER from the beginning? I feel like I know the answer to this question.
I would say I wasn't 100% sold really on anything. I definitely had an interest in emergency. And I would say arguably that while I was on clinics, ECC and ICU were my favorite and most memorable rotations. And the funny thing is that my criticalist that I work with now was actually my resident when I was a student.
Oh, no
so
kidding.
crazy small world. Yeah. But I mean, at the same time, I loved surgery. And a lot of times in vet school, I mean, everybody gives you a different perspective on what they would recommend you go forward with, whether it's internship, residency, starting general practice, I mean, there's so many options, and it's hard really to decide what is best for you. And I definitely had trouble deciding what I wanted to do. And then I met my now husband, who practiced law in Gainesville, and we share custody of his son. So when I was looking for a next step after vet school, I really, wanted and really needed to stay local. So when I was looking, I was really open to anything. I was open to internship. I was open to general practice, emergency. And I happened to find a position at Newberry Animal Hospital, which is where we met.
Yay.
And they offered me, a position as an associate veterinarian in their general practice. And so I don't know that I necessarily knew right away, but I had an opportunity, presented to me, and I ended up taking it. And over the course of the last couple of years, I have probably gravitated towards seeing the emergent cases. Everybody always jokes, that my shifts are a little chaotic, because I do like those cases, I like seeing them. And so I think over the course of the years in general practice, it definitely made me more and more interested in pursuing emergency.
So I feel like some that I knew already, but like so evident why we get along so well.
Yeah.
Because I also, emergency was one of my very favorite rotations in school. And I loved ER cases. I worked in the ICU before I went to vet school, but it was kind of the hours and things that have made me gravitate more towards general practice, which I want to ask you more about later. But also, I like to say I met a boy, and then here I am in Gainesville. So I was also geographically limited. And I don't know that I gravitate towards those cases quite as much, but yeah, I certainly get the same thing where they're like, Tuesdays, which are the days that I'm over there, they're like, this is just wild when you're here. And so I don't know if I gravitate towards them or if they just find me.
They find you.
But they are exciting, and it kind of, it gives you an interesting twist in your day to have to manage some of these more critical cases. And then you say, I feel like you glazed over it very briefly. Like, I liked surgery. You did like surgery, and you were very, very good at it from the beginning. Like, immediately, I'd been out, I think, 6 years when we met. And I immediately was like, here, you want these surgery cases? You can have them. Do you find yourself cutting a lot in ER?
So it's very hit or miss. And I am very lucky to have, a board certified surgeon in my building. The hard part is most of the time I get busy with my emergency cases. So I don't get to cut a lot, but I do get to cut, and the cases that we cut, of course, are emergent. So they're very exciting, but I don't get to cut quite as much as I would like to.
Sure. Yeah, and like you said, they're emergent when you're cutting them, and then probably I would imagine that makes the anesthesia really interesting too.
Yeah.
And
But we have a great anesthesia team too. We have some really, really great technicians, and in general practice, I was actually really used to making my own anesthetic plans, and now I'm able to really pass off the patient to my anesthesia team, which is nice because of course I'm involved, to some extent. But it is nice having, we have a great team that can really come together with those cases. And then, of course, I get to manage them after too, which is pretty cool. But I do get to do surgery, and it's really fun.
Yeah, well, good. I'm sorry that you don't get to cut quite as much because I know you're good at it and how much you enjoy it. But that is cool that the cases you do get to cut, you really, there's a lot that goes into it when you do cut it. I think I was texting you the other night and was like, will you cut this case tonight?
Yeah. And it's nice because I get to intake them, manage them beforehand, sometimes cut them myself, and then continue to manage them after. So it's kind of a nice start to finish to be able to see the whole clinical picture, with the animal, which is not something that we often get to do or that I didn't get to do in general practice or.
Right, because these are hospitalized patients rather than you kind of send them home and hope for the best.
Yeah.
Sure. Very cool. How do you feel like your time that you spent in GP kind of affected your decision to go into ER and then your practice now that you're in ER and emergency medicine? Because, you mentioned you were kind of on the fence in the beginning, kind of open to all the possibilities, not sure if emergency was the way to go. So went from general practice to emergency. Do you feel like that was the right flow for you? How has that affected the way that you practice?
So I would say in general practice, you truly do. I would say it's more of low-key kind of emergency, I mean, you see a little bit of everything, right? So, and same thing in the emergency room. You see truly a little bit of everything. And so I think general practice made me feel comfortable, not really knowing what was going to walk in the door. But also, I mean, I had those, scheduled routine patients, things, annual exams, vaccines, allergies, things like that. And so it was a nice mix of, potentially seeing something that wasn't as it seemed, and having good, planned, scheduled things. That was a balance, that would make me feel more comfortable seeing those weird cases, because I had that extra time that I could, put towards them. In the emergency room, you don't always have the luxury of time. And so having that background of being able to take my time with some of those weird cases in general practice, I think has now helped me make faster, and better clinical decisions in emergency. But it really was over the course of the couple of years I was in general practice, I would just see more and more emergencies because I just loved them.
Right.
And then I did express some interest to Newberry Animal Hospital, that I was interested in pursuing, emergency medicine. I had actually started picking up relief shifts, in emergency rooms. And, a couple years later, they decided to open this, new practice. And they asked me if I wanted the position. And I, without hesitation, agreed right away and have never looked back.
I remember that. We were at one of the Christmas parties and you were like, they asked me if I want to go to the ER position. I'm like, absolutely I do. You were so excited. Your eyes lit up. And I think there was no doubt for, those of us that were still in the general practice side of things that were like, yes, we were super sad to see you go because A, we love working with you. And then B, like, any crazy case we got, if it got too crazy, we'd be like, hey, do you want to jump in here? And you're like all about it. But yes, I remember like just the excitement. And it's a really cool position. And I love that, like, now I'll text you like crazy questions where I'm like, what do I do with this? Because it's just not something that I see on a regular basis. And like, you're always super fast and you're like, here, do this, this, and this. And I'm like, oh, thank goodness. Where do you feel like the biggest learning curve was for you in that transition?
So probably the first three to 6 months when I started. And so it's been a little over a year since I started full-time ER. But I think the biggest learning curve definitely was in the first few months. And I was actually very lucky to be able to attend IVEX last year in September. So I started in June and then I was able to go to IVEX in September. And I feel like fundamentally that really changed a lot of things for me. I mean, I was, a lot of people go to conferences for fun and socialization. And I was that nerd that was in lecture, from 8 a.m. to 5 p.m. Everybody's texting me, let's go out, get some drinks, let's go hiking. Because we were in Denver, Colorado. Yeah. It's beautiful. And by the time I was out, the sun was setting.
Right.
So, but I loved it. I spent my entire day, in lectures learning, going to those lectures where I still, things that I didn't really learn in general practice, like giving blood transfusions, how to give antivenom. In theory, you learn those things in school, right? But when it comes down to it, it's like, oh crap, what do I need to do? I need to look through my notes.
Right.
And so it was really that. It was kind of learning how to use the resources available to me that I never had. And seeing those patients, a lot of times, we'd have patients that came in and it was above our capacity for what we could handle. So, if we got a call, if a patient came in with a snake bite, we would send it off. Oftentimes even with cats that would, develop urethral obstructions, not something that we could really manage easily in general practice. Occasionally I did get to unblock a cat, which was amazing, but being able to spend the first couple of months learning all of the different things, all of the resources that I had in the hospital, that was probably, the biggest learning curve for me.
I love that you bring up the snake bites because I have come to see you to be like, what, can I please have some antivenom? Because I have a snake bite and you're like, here's what you're going to do to give it. And I was like, great. Now I don't have to look it up. And you're like, here's what to watch for. Here's how to give it. You can give that super fast if you need to.
And a lot of times, no two patients are ever the same in the emergency room. So, one snake bite versus another snake bite could be totally different, which is also really exciting. But same thing. I mean, I would say there is still a learning curve. I still, every day, I'm like, I go back and forth. I change my plan every 5 minutes if it's what's best for the patient. So I don't know that the learning curve ever stops, but definitely, after the first couple of months and getting more used to the resources I had available to me, and my technicians are absolutely incredible. I mean, I bounce things off of them all the time and keeps me sane. Kat Temple, my criticalist, is also, pretty much always available at any given moment. So I call her just to pick her brain sometimes, but I think I definitely had a lot of anxiety and stress the first couple of months. And then once I started getting more used to the things that I had, the drugs I had, some of the things like NG tubes and chest tubes. And, so I definitely think I feel much better now about my ability to kind of jump in. And I would say certainly I am much quicker now with my plans than I was when I first started.
Sure. I'm thinking about what you said here, and I'm going, if somebody handed me an NG tube, and I would be like, but there's this red rubber, and I have this butterfly catheter that I can use. What do you mean? For a chest tube, I'd be like, I just tap it with this thing, and then it fills up, and I tap it again. What do I do with this thing? So I could see there being a big curve there of just learning how to use that equipment and getting comfortable with it, because that is really different. And I'm glad you brought up your team, because I was going to ask you, about just the support there. I feel like medicine in general is such a team sport, but especially emergency medicine, where things are changing so quickly and patients are critical. You have to catch every little thing very promptly in order to treat them successfully. Just the importance of having that good team approach and technicians that you can count on and that can count on you in order to get successful results. Yeah,
and my technicians are absolutely wonderful. Some of them, are even, I would say, arguably more comfortable than I am doing some things, as they should be, right? In some cases, I can order a central line and it gets done, and they're all very eager to learn. There's nobody on the team that says, oh, no, why don't you do it? When I ask, who wants to unblock this cat? Everybody raises their hand. So it's nice to be able to teach them the things that I know, but it's also nice to be able to learn the things from them that I never learned in general practice, like placing a central line. So yeah, they're absolutely amazing.
We get to benefit from that a little bit, too, in the sister hospitals, because we'll have in particular, anesthesia, we'll have our lead technicians go and rotate through over there and handle some of the more critical cases with some different techniques and blocks and things like that. And then I've had that same experience where they come back over and all of a sudden they're teaching me something that I've never seen before. And I'm so appreciative of that give and take, because just we get a much better result. And yes, in that comfort level, because the first time they're like, we're going to do this. I'm like, are you sure? Is that safe? I've never done that before. And when it works out great, then all of a sudden you have this new tool in your arsenal that you can use. That's a mixed metaphor.
I know, right?
Have you ever used vitamin C to unblock a cat?
I have not. There's
a lot
of anecdotal reports about it, but I've never, to be honest, I've never needed it.
Do you have it if you were to need it?
We don't. No, we don't have it.
Because it's like a reptile thing.
Yeah.
Yeah.
And it's kind of I would say, I hate this term, but it's kind of an old school thing.
Okay.
But yeah, I honestly have never needed it. Sometimes what I will do is I'll instill a little bit of lidocaine into the urethra. And I know, a lot of people do that, and that works really well.
Okay.
But most of the time, and if our anesthesia team is around, they actually will always do sacrococcygeal blocks on these patients. So it's amazing. And they've actually started to teach us in the emergency room, me, my technicians, how to do those things too. So yeah, I've never needed the vitamin C.
Okay, that's good to know, because my best friend told me a story about when she had to go down the street to an exotics practice and get it, because she's like, everything she tried was not working on this cat. And since then, that's been my biggest fear, is that I'm going to get a cat I can't unblock and I'm going to need vitamin C. And I'm like, where do I get the vitamin C? How do I do this? But yes, I think lidocaine is a good technique. And I think those sacrococcygeal blocks, I've been trained to do them multiple times. And it's one of those things like putting a needle in a chest where it's when you think about doing it and you haven't done it a lot of times, it's like, you're like, I do what? Are you sure? Like, this is really scary. But once you do it a few times, it's like, okay, this is fine. I'm still in the scary phase with the blocks. I need to get better.
Yeah. And I mean, it's one of those things you just have to do it, you know, and the more you do it, the more it becomes muscle memory. It's really just one of those things you have to do it.
Oh, yeah. Oh, yeah. They do so well with it, and it just relaxes everything.
Relaxes everything. Yeah. The only time I would say there was one patient that we had that we couldn't unblock. If you can't tell, I love unblocking cats.
It is so rewarding. When you get it, you're like, yes.
He had a stricture. So no matter what we did, and, I tried, Dr. Stanley, Jesse Stanley tried, and we ended up having to go into surgery to try to divert the stricture, basically. And so he did do a PU that evening, but that was probably the only case that I've had that we could not successfully unblock.
And you found the stricture like at surgery? Mm-hmm. Okay, that makes sense. It didn't matter what you did in that case.
No.
Oh man, I had one that I still think of that I couldn't unblock, but it was like a Hail Mary type of case, and we never found out why we couldn't get it unblocked. But it is very rewarding.
Maybe there was a stricture.
Maybe there was. Now that's in my brain. I'm gonna go with we're gonna go with it was a stricture.
Yeah. It makes the most sense, right?
Absolutely, absolutely. We tried it. What I feel like was everything in this cat, but some of them you get those weird ones every now and again.
Yeah.
So knowing what you know now, what would you say if a student was rotating through with you and said, I think I want to go into emergency medicine? Would you tell them to, do an internship or a residency? Would you tell them to go straight into ER? Would you say maybe go into GP first?
So I would say for me, I don't know that I would necessarily recommend an internship or residency because I didn't do one. So it's hard for me to recommend something that I haven't truthfully been through. What I would tell them is to, one, in school, really soak it all in. Ask the quote unquote, stupid, not stupid questions. It doesn't matter what anyone thinks. It doesn't matter what you think about your question. If it's something in your head, there is somebody else that is also very likely thinking it.
I have made a living out of asking stupid questions. Like, that's what I do here. Right. So yes, I agree. Ask all the questions.
Ask all the questions and don't be afraid to do that. Really, really soak it all in. If it is really something you're interested in, I know when we were prioritizing what rotations we wanted on clinics, we were able to kind of pick and choose, and say we wanted XYZ. I had 2 ECC rotations and an ICU rotation. Unfortunately, my second ECC rotation was in March of 2020 during COVID, so I didn't actually get to do it. But I prioritized that when I was choosing my rotations. So having those extra, even if it's just a couple of weeks here and there, it makes such a huge difference, especially when you're in a tertiary referral teaching hospital. There are so many things you can learn from every case, every patient in there. And then externships. I regret not doing more emergency externships. I did a lot of research with, I know this is completely off topic, but I did a lot of research with sea animals, with sea turtles in particular. So a lot of my externships were kind of doing work, continuing my research with sea turtles. And then I had a couple of surgery externships as well, but I never did, any emergency externships. So I think, that is definitely something I would recommend doing if you can shadow in a local practice, just to kind of see the caseload, kind of see what they do, what it entails, the hours, if you feel like it's something that you can handle, if you don't, get super stressed or anxious. If you thrive in that environment, doing it and being there and seeing it is going to be the way that that. And I would say certainly on clinics, don't be the person that stands in the back and watches. Ask the technicians or the faculty, resident, whoever's there, ask them if you can unblock the cat. Ask them to help you with POCUS. Ask them, to teach you how to do the thoracocentesis. So those are moments and opportunities that you'll never get back. And one day when you're out in general practice or emergency or whatever you're doing, you're going to realize, I've never done this before. And sometimes there's not always somebody around to show you how to do it, and you have to figure it out. And, most of the time it works out okay. But I would say certainly truly soak it all in, and try and get your hands wet.
I think that's such good advice. And I would add to that, in addition to doing the procedures, when you're talking to the technicians, maybe even ask to set up your own CRI, handle these drugs, because I know that's a big fear point for me where I can look it up and it's like, use this drug at this dose. But if I've never physically seen that drug or held it in my hand or mixed it up, like there's this fear of like, am I doing this right? I've never done it before. So if you've at least if you're like me, if you've held it, you've seen it, you've drawn it up, then it's a little less scary to, when you get one of those weird cases that needs a drug that you're not comfortable using, that you haven't used a whole lot, at least you've seen it before, and it takes a little bit of that fear factor away.
And the technicians, truthfully, know better than the clinicians do how to dilute the drug, how long to give it over. Those are things like, we know the dosages, sure, and we can put in the dosage, but the technicians are my resource for, hey, are these two drugs compatible in the Y site? How do I dilute this? How long do we give it over? And so that is definitely, I would definitely pick everyone's brain. Everybody has such good knowledge and they're all such good resources. So I would 100% agree with that.
And then I also want to circle back to, you said, there's not always someone available to help you. And most of the time it goes okay, but that can put you in a really tough spot, especially as a new grad. In the case of us working together at the hospital, I felt so terrible that you were with me when you were doing some of these harder surgeries. I was like, you're probably better at this than I am, but I'll help where I can.
Not the teeth. You got me on that.
Yeah. See, but you say that, but then like I worked with you on a few of them, and now like I'm pretty sure you just don't like them, but you're actually better at them than I am. It kind of, it's one of those where it like makes my eye twitch a little. I'm like, gosh, and she's better at it than I am. So I guess my saving grace is that you don't want to do the teeth. So I'm like, okay, good, I'll keep the teeth. But I'm thinking of some of these bigger surgeries. You did have, we talked about Jesse Stanley, who has a surgery-focused practice now as part of community care where you work. And he would come in and kind of assist with some of those surgeries. So I'm curious to know the role of mentorship with liking surgery, feeling comfortable with some of these more critical cases. Because I think of my surgical experience when I started out, and I did not do surgery externships. I did dairy cattle externships, and went a completely different direction in my career. But I really didn't have a lot of mentorship in terms of like good surgical technique and things that I felt comfortable with. And I really think that probably is part of why I don't like surgery today. So I'm curious to know how you feel like that affected your experience.
I had, honestly, an amazing experience with Dr. Stanley and Dr. Spinoza as well. So luckily for me, when I was hired, they were kind of piloting a mentorship program. It had not been something that they had done before. So I was a little bit of a guinea pig, but I certainly did not feel like one. And the great thing about Dr. Stanley is he would be available during my surgery days, whether he was sitting in the OR with me, whether he was scrubbed in, whether he was in another room, doing paperwork. He would always come in and ask me what I wanted from him. Did I want him to hover? Did I want him to just kind of sit in the corner quietly and jump in, if I needed him? So it was nice in that aspect that I had him there if I needed him. In some cases, there were surgeries I, had never done before, and he was the one that taught me how to do them. I did my first cystotomy with him, my first RNA with him. He taught me how to, do a GDV. So there were a lot of, in quote unquote, emergent, not so emergent things, but we did a little bit, of everything. And he truly taught me mostly everything that I know. So it was nice having him there, and he would come into my surgery days every week for probably close to 6 months. So that was incredible. And I learned so much. And even after the 6 months, sometimes I would call him and say, hey, I have this surgery. I'm not super, comfortable. Can you just pop in, and just kind of hang out? And he would make the time, he would rearrange his schedule. And he would be there without hesitation. So that aspect for me was really important in developing my surgical skills with things I had never really done before. I was very comfortable with spays and neuters, and I had done, maybe 1 or 2 gastropexies, but that is also something, that he taught me how to do. And so I became really comfortable with that because I had him as backup every time. And then from a medical perspective, Dr. Spinoza was my resource. So when I had cases that came in, I also had, Dr. Greg Long, I had Dr. John Mathers. So I had a good little support group, where I was, and I could pick any of their brains at any given moment. And every week, Dr. Spinoza and I, we would have lunch together and we'd we'd pick 2 or 3 cases and we'd kind of debrief about the cases. And so I think that was helpful for me, especially as, she's a seasoned veterinarian. She's seen a lot of things and has really good, clinical practice experience. And so that was also helpful for me in developing clinically and realizing, in hindsight, sometimes after we'd review these cases, okay, I need to remember that, for next time. So the mentorship program, 100% would recommend. Whether you do an internship, maybe if you do a residency, probably don't need it. But I would say, especially if you're going, blindly into practice, I would strongly recommend a mentorship program of some sort.
I love listening to you talk about it because I kind of got to witness it secondhand as it was going on. And I was like, wow, this is really great. I specifically remember Dr. Stanley being there one day and you had called him in on a surgery and it was like a splenectomy or something without a ligature where you're tying things. It was something that you could definitely do.
Which I will never do ever again.
Right.
Let me just say.
Now you're spoiled. Now you have the ligature.
I'm too spoiled now.
But it was something like you could definitely do and he knew it. And I just remember him like walking around the OR like trying to work on something. And then he's like, can I go now? Like, are you good? He's like, I'm just giving you a hard time. And then Dr. Spinoza, I 100% agree. I always say she walks in at the exact time I need her somehow. Whenever I have a weird case I can't figure out, somehow that's the moment she walks in the door and I'm like, oh, thank goodness.
Thank God.
Help me.
But yeah, and Dr. Stanley was great in that aspect. I mean, he would, and he was very much, joking around when he was being playful, but he knew, and he was confident that I knew what I was doing. And he really pushed me. I mean, there were times, he wouldn't even scrub in. He would just kind of stand there and, I would say, hey, are you going to throw some gloves on? And he would say, no, I think you're okay. So it really taught me to be self-sufficient. But, it was definitely nice to have him there to kind of give me that little extra boost of confidence too.
Absolutely. And I think you made a good point too about even some of, the more GP focused, Dr. Spinoza, of course, being one of them. But, you mentioned Dr. Long, Dr. Mathers, having some seasoned GP veterinarians there who, weren't surgery focused to say, yeah, I've seen this before, use this drug, approach it this way. This is what it might be. That was like that was a good team.
Yeah, it was a great team.
Yeah, we did some cool stuff.
Yeah, we did.
I want to keep going down memory lane here because it was good times we had. But I am curious to know about the hours because I know, that's one thing that really, whenever I would consider emergency medicine, the hours were one of those things that were a challenge. So I'm curious to know your schedule in the ER and kind of how you handle the non-traditional working hours.
So my schedule any given week, I work 3 to 4 shifts, and my hours are 3 p.m. to 12 a.m. And then the shifts that I am working, I am on call overnight. So when we are hospitalizing patients overnight, if we have inpatients, the technicians can call me between the hours of midnight, which truthfully, I would say my hours softly are 3 p.m. to midnight. Realistically, I probably get home, around 2.
Sure.
But from the time, my shift is over to the following shift in the morning, so until 5 a.m., I am on call for any of the inpatients that we have in the hospital. And then at 5 a.m., it gets bumped to the morning doctor. So we don't have a doctor in the building overnight, and that's kind of why I am that go-to person, which also limits us a little bit in our hospitalization capacity, with critical patients, things that potentially need ventilation or, something that really could benefit from having a DVM in the building overnight. I would say for me, I am very much a night owl. So the hours for me, I truly feel like I have an entire day before I have to go to work. Whereas, when I was working in general practice, I would get there anywhere between 7 to 8, maybe 8:30 in the morning. And I would stay between, maybe 4:30 to 6:30. So it seems like the whole day at that point was over. I'd get home, maybe do a quick workout, I'd have to make dinner. And then it was really, maybe we watch TV for an hour and go to bed. So now with my hours the way they are, even if I'm getting, 7 or 8 hours of sleep, I'm still getting up by maybe 9 or 10, and then I still have 3 or 4 hours. And for some reason, it just feels like a lot more time that I have during the day. And I'm a lot more productive before I go to work than when I get home from a really long, tired day. So the nice thing about my schedule is I can go home, I can unwind, and I can go straight to bed. And I don't have any tests to do. I don't have to cook dinner. I don't have to go to the gym. It's all kind of like I get to come home, unwind, and just go straight to sleep. So in that aspect, I love it. And I've always hated waking up early. So
that works out perfectly.
It works out great for me. The hard part is, especially, when you have a family, there's a lot of nights you miss dinner, you miss events, especially in ER. I work, 2 weekends out of the month. Sure, I have the mornings, we can have breakfast together, things like that. But there's a lot of things that I feel that I miss out on. So from a long-term perspective, I don't know, that it's something that I will do forever, but it works for us right now. And I think it really just depends on your lifestyle, what your situation at home is. And especially, if we decide to someday have a child, we have my stepson, but he's 12. He's basically self-sufficient. He feeds the dogs, he does chores, it's fantastic.
What is that like? My gosh.
But I do feel like I miss, spending time at home. And at some point, our plans may change, and eventually, maybe we kind of reevaluate. But it works for us right now, and I love it.
Well, it sounds like, kind of taking the good with the bad, similar to the traditional hours. Like you said, you do have more evening time that you can block off a little bit more predictably in the evenings when you're doing the more traditional GP hours. But like you said, if you want to go to the gym before work, you're up at like 4 or 5 o'clock in the morning, and, you get home and you're tired and you still have to do all the things rather than just being able to unwind and go to bed. So it sounds like there's positives and there's negatives to both. And you just, like you said, you have to find what works for you. It also seems like, at least in this area, kind of gone are the days of like the only nighttime ERs. We're seeing more and more like 24 hours and extended hour ERs. So, maybe if you have your time in X, Y, and Z shift, then, look for a place where it would give you the opportunity to work day shift.
And they actually did ask me if a couple of months ago, we were making some scheduling changes, and they asked me if I wanted to switch to day shifts. And I said, absolutely not.
This is good right now.
This is great, for now. It works, It works for us, so.
What would you say is aside from unblocking cats, your favorite part of working ER?
I would say I love that no 2 days are ever the same. Truly, no 2 days are ever the same. There's never a dull moment. There's really nothing that I don't enjoy doing in the emergency room. In general practice, sometimes, we'd see the same cases over and over and over again. And of course, we still have, we do see the blocked cats. We do see, the snake bites. And sure, are they the same, disease process? Yes. But managing each case is so different, from one patient to the next. I would say that is probably the best part of ER, is it really actually keeps you on your toes.
I could see that. I'm also thinking with like those long-term follow-ups where, like you unblock the cat, but then you don't have to go make sure they're doing the right diet like you told them to and doing all the things. Or, the Addisonian crisis, you get destabilized, but then don't have to chase them down to be like, gosh darn it, like give the medications the way I told you to. And you can do those emergent cases where, some of the more frustrating parts of those chronic cases fall back into GP. And truthfully, like I tend to actually really enjoy that part of the case and enjoy that part of GP. So not to make owners sound terrible or diminish anything with GP, but I could see where you say like you enjoy doing, there's nothing you don't enjoy doing. I feel like it makes sense from a standpoint of where some of the frustration comes in is in that follow-up. So when you get to do the procedures and be hands-on and you're like, I fixed it, now go over there. Yeah. That seems like I could see that being very appealing.
Yeah. And I would say because I spent so much time, I guess it wasn't that much time, but because I spent a couple of years, in general practice, I do realize the follow-up aspect of a lot of these cases, whereas people that have only ever worked in emergency, they don't really know what it entails. We say in our discharges, please follow up with your primary care veterinarian in 3 to 4 days, 5 to 7 days, 24 hours, whatever it may be. But for me, I can go that little extra step and prepare the owners for what's to come because I've been there. I have been that general practitioner managing the Addisonian or managing, the cat with fluted. So it's nice to have that little extra bit of information that I can provide, for these patients. I mean, even something like IMHA, which is certainly something we see a lot in general practice. Certainly something we see a lot in the emergency room, and those patients are managed, for months. And I'm sure you and I have a case
of the century.
Yeah. And the internal medicine case of the year, right? Yes. So, and it's in those patients, one where, I can work closely with the general practitioner who luckily happens to be a close friend, but also knowing that, I know what the management is like with these patients. So it's something that it's not like, here's what we can do in the emergency room, and then we don't talk about what happens after, right? And I think that is really important for owners to know, what comes next. I mean, if we spend XYZ amount of money to stabilize this patient and get it through this crisis, what are we really looking at afterwards? And I think that is something that probably, most people don't realize. So
that makes sense. And it is really helpful on the GP side of things to, one, have a patient come back and have some mental preparation of what we're getting into once they're stabilized. But also, I think it gives you an appreciation for what we can and can't do in general practice. And so, maybe if you do have a money case where you need to do all these things and, the funds just aren't there, what's realistic in general practice. So it might be something where you can say okay, I can take you this far, go back to your GP, and then they can take you the rest of the way. Right. And that's something that is reasonable in general practice versus listen, we're here or bust because it's not going to go well if I send you back.
Yeah, and it's nice in that aspect because, there are cases truly where, they're like, well, do you think we can just wait until tomorrow to see the primary vet? And, in some cases I'm like, sure, the pet looks great. The vitals are normal. They're very stable. I can't tell you 100% because I don't know really what's going on. But there are other cases where, the answer is absolutely not. Right. And it's kind of finding that, that fine line between the two and preparing owners for the expectation of, if they go back to their general practice, this is kind of the options that they're going to have. And so it's nice to be able to at least provide that for clients.
I think that's a really good endorsement for doing some time in general practice and understanding, because I came from the tertiary referral world. I did not work in general practice before I went to vet school. I was purely at UF. And so I did not understand how general practice worked and the importance of having those regular relationships with your veterinarian and that understanding of your pet and knowledge of your pet. So I think that's a really good plug for saying, spend some time here, understand how this works so that we can support each other on both sides. And I know you said there's nothing you don't enjoy doing in the ER, but is there any single case? I'm interested in a least favorite. Is there one where the phone rings and you're just okay, fine? Honestly,
I would have to say DKAs because I love managing them, but they're so different, from case to case. And that makes it so challenging with those patients. And the hard part is, sometimes they come in and they look terrible. And then 24 hours later, they're running around, they look fantastic. But the opposite can also happen. Sometimes they come in, they don't look so bad. They're maybe a little quote unquote ADR at home. And then we go the opposite direction, despite everything that we're doing, sometimes we lose that battle. And so I would say I hate how unpredictable they are, but they are very rewarding, when they go well.
Right.
But those are the cases, when we get a phone call from an RDVM, there is definitely a little sigh that comes out of my mouth.
Okay. And we were just talking before we turned the microphones on about, with the oral, the SGLT2 inhibitors. Now we've created a whole new challenge with DKAs. Yep. and
especially in the ER. Yeah.
And I have to agree with you. I also don't love a DK, especially like those DK, because, thinking from the GP side, we'll get those really terrible looking DKAs that come in. We're like, no, you have to be hospitalized. Like we can't manage this outpatient. But I have successfully managed DKAs outpatient in the ones that really don't look so bad. But you're absolutely right. It's completely unpredictable. Every case is different and they can turn very quickly. So I also, and I love endocrine disease, like the pathways, I just nerd out on them. But yeah, DKs are one. I have the same reaction where I'm like, okay, fine. Let's do it. Well, I could seriously sit here for another hour and talk about all these different things. And I feel like you and I definitely would, given the opportunity. But, I want to respect your time here. So thank you so much for joining me. Are there any final thoughts you want to share with anybody?
I don't think so. Thank you so much for having me. This has been really fun. I know we got off topic a couple of times. Not that I was completely not expecting that.
Exactly.
But yeah, no, I think we've covered everything.
Wonderful. Well, now that I've talked you into coming in once, I hope I can talk you into coming back, because these are such fun conversations. Maybe we can dive into like some specific cases at some point.
Yeah, that would be great. Honestly, I think you and I could probably sit here and talk the entire day. So yes. I would love that.
I would love it too, although not the internal med case of the century. We'll leave that one to the sidelines until we're sure we're done with that one. Well, thanks again. This has been a lot of fun.
Thank you so much.
Thank you to everyone who joined us for this episode. I want to say a huge thank you to Dr. Shah for joining me. What a great conversation. I truly hope we can do it again sometime. So, to anyone listening who enjoys this episode and you want to hear more about specific emergency cases, please email me at dvm@vetfolio.com. Let me know what kind of emergency cases you want us to talk about, and let me see what I can do to make that happen. If you enjoyed this episode, please leave us a 5-star review wherever you get your podcasts. It'll help other veterinary professionals like you find this and other great content we try to put out there. For more episodes like this, click on the Education tab on the VetFolio website. As always, we'd love to hear your input on this talk, as well as ideas for topics you'd like to hear from us in the future. Feel free to reach out to me at dvm@vetfolio.com. You can also visit my Facebook page at Dr. Cassi DVM, and now you can find me on Instagram at dr.cassi, CASSI.dvm. And remember, if one animal is better off because of you today, it's a great day.